The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the Health IT Safety webinar. Today's topic is EHR Usability and Health IT Safety. Next slide, please. Just a couple of housekeeping items before we start. Everybody will be have their lines muted because of the number of attendees, so please use the question panel to pose any questions that you'd like for our panelists. Closed captioning for today's session is available at www.captionedtext.com. The Q&A will take place at the end of all the sessions, and slides are already posted at healthitsafety.org. If you have any general questions about the ongoing webinar series, please contact us at healthitsafety@rti.org. So today's webinar is one in a series of 10 that we are providing under contract to the Office of the National Coordinator. RTI, a nonprofit research organization, has been working on this as part of a year-long project to help the ONC develop a roadmap for health IT safety. And I'd like to introduce today's moderator. Dr. Jonathan Wald is Program Director for Patient-Centered Technology at RTI. Take it away, John. Thank you.
Great. Thanks very much, Michael. If we go to the next slide. So this is Jonathan Wald. I'll be serving as moderator today. And we are going to have, I think, a very interesting set of presentations. We've got 3 presenters. And I'll introduce them in more detail as we begin. But we'll be hearing from Raj Rotwani, who's the Scientific Director for the National Center for Human Factors in Healthcare at MedStar Health, from Chris Engdahl, who's a Senior Manager of User Research at Athena Health, and from Ross Teague, who's a Senior Manager of User Experience at Allscripts. Next slide. And we're going to begin with Dr. Rotwani. And as Michael mentioned, what we'd like to do is have each of the 3 presentations in turn. And that'll take us through the first hour. And then we will have questions and answers with all of the panelists at the end of the hour. So that should give us another half an hour for Q&A. Dr. Rotwani, as I mentioned, is the Scientific Director at MedStar Health's National Center for Human Factors in Healthcare. He's also an Assistant Professor of Emergency Medicine at Georgetown, and he studies the design, development, implementation, and use of health IT with a focus on safety. He studied it from the perspective of several different stakeholders, frontline users, vendors, and patients, and has a specific area of expertise in usability, visualization, and human error. Dr. Rotwani will be presenting today from frontline users to vendors. What are the current health IT usability and safety challenges? Next slide. And on to you.
Great. Thank you, John and Michael, for orchestrating this wonderful series and inviting all of us to come and talk today. And thanks to the audience for taking time out of your day to listen. I'm going to talk a little bit about some of the work that we've been doing that touches upon health IT and specifically EHR usability from the frontline perspective, and also some of the challenges that we're seeing with health IT usability. Next slide, please. So to start, as they say, a picture's worth 1,000 words, and some of you may have seen this picture. This photograph was taken by Dr. Bob Weirs, who's one of the collaborators of ours. And this was taken in the emergency department several years ago when he was conducting one of his studies. And I think it speaks volumes. If you look at what all of the clinicians are looking at, they're all looking at the traditional whiteboard and using the traditional whiteboard on the left side of the photograph. And on the right side of the photograph, you see this wonderful piece of technology, the electronic whiteboard, that nobody's using, that nobody's interacting with. And it stops you for a second, and you have to wonder, why on earth is nobody using this incredibly expensive and probably a lot of time invested in developing this product? How come nobody's using it? And if you're able to actually zoom in on the electronic whiteboard on the right-hand side, you'd see that it looks quite nice. It looks like it should be a usable system, yet nobody's using it. And one of the reasons that nobody's using it is because it doesn't support the cognitive work processes of the clinician. It doesn't support the way clinicians actually do their work. And much of that, I think, can be attributed to poor usability. Next slide, please. So today I'm going to talk about some of the work that we've been doing to measure the impact of usability on frontline clinicians, and then on some vendor usability processes, but I certainly don't want to just focus on vendors, so I'll try and touch upon a couple points, although there are two great vendor speakers coming after me, which would certainly be able to clarify things. Before we really jump into all of that, I want to start to talk about usability in general, and there's lots of great definitions of usability, and there'll be a formal one following the slide, but sort of a more simplified explanation of usability that we like to use around our center is to describe usability as having two bins. One is the user interface design bin, and this is really about what the interface looks like. Things like the font size, the colors that are used, the iconography, and clicks and drags. And so this is one core element of usability, and of course these two bins overlap. And if you look at the interface design elements, it turns out that many of those issues were actually studied and solved 10, 15, 20 years ago in the traditional human factors literature. We have good insight on what particular colors are most effective. We know what colors convey pressing information versus colors that convey information that's not so pressing. And so we have really great insight there, yet we're still seeing some pretty gross violations of these even basic user interface design elements in many of the EHRs and health IT tools that we're seeing rolled out. But in addition to that is the bin 2 stuff that's on the right side of the screen. And the bin 2 stuff is really about supporting the cognitive needs of the user. So this is, how do we actually build and develop visualizations that support the way people integrate information? How do we take our deep understanding of how humans think and reason and design the interface and the entire workflow and system so that we're actually supporting users as they do their work? And it turns out that this cognitive task support bin is incredibly, incredibly challenging. It's challenging in healthcare, and it's challenging in several other high-risk industries, and really is where a tremendous amount of investment needs to be made. It's not easy at all to study the way people actually do their work, particularly in medicine, given the several different subspecialties and the several different permutations of workflow. But this is really what needs to be done to push usability to the next level and build tools, electronic whiteboards, EHRs, that actually support users. Next slide. So I'm going to start talking about, well, I'm going to provide a formal definition of usability here, and I think both Chris and Ross will probably get into some more detail about this. But if we look at the ISO definition of usability, it's the extent to which a product can be used by specified users to achieve specified goals with effectiveness, efficiency, and satisfaction in a specified context. I think most people would agree on this formal definition of usability. And it turns out that there's a fairly robust process to achieve usability through user-centered design, and of course there's other methods as well, but user-centered design is one that has seemed to be successful in several industries. And user-centered design is about putting the needs of the end user at the forefront of the design and development process, and to do this in a very iterative fashion. So you start by identifying user needs, and in the case of healthcare, it would be immersing yourself in a clinical environment to understand how clinicians actually work, developing some initial wireframes, and then consistently and continually iterating such that every time you're advancing your product through development, you're getting user feedback and building upon it. So I'll talk about some of the policy stipulations around user-centered design, and we'll talk about what vendors are doing to that end, but I do want to make it clear that there certainly is a well-recognized process in place to achieve great usability. Next slide. Our approach to studying usability, specifically for electronic health records, is given that we're immersed in a large healthcare system at MedStar Health, we're part of a 10-hospital system, is to continually get in front of frontline clinicians to understand the challenges that they're facing on the ground. So the first study that I'm going to talk about is actually focused on the implications of a new EHR from the perspectives of a frontline user, and particularly focusing on the cognitive implications. So this very much drives the way we think about usability, and I think grounds us quite well. But in addition to that, we've also worked to develop a really deep understanding of both vendor and provider processes, challenges, and barriers. And we've done that in several ways. From the provider side, we've been involved in some of the decision-making that happens at MedStar, and we've seen how challenging it is to actually compare usability and pick out products and systems. And from the vendor side, we've done studies where we've gone to visit several different EHR vendors to understand the use and usability processes they have in place and the specific challenges and barriers that they face. And finally, we've also done a fair amount of policy work looking at how usability policy actually influences the true usability of products and what that means for vendors and providers, and I'll touch upon that a little bit later in the talk. So this is meant to give you an idea of our background and where we're coming from. Next slide. So jumping into the first study that I'm going to talk about, looking at frontline impact, in the summer of 2013, we went live with a new commercially available EHR to replace a homegrown system that we had in place. So it was a replacement, and with the replacement came a new CPOE capability that was not in place before. And we were really interested in understanding what the impact of the new system it was going to be on clinicians, and in particular, we focused on the emergency department and we focused on physicians. And what we did is we focused on 3 different study periods, created 3 different study periods. We went in and did observations with the current homegrown system before the new system came in place. We then had a study phase of looking at that initial week of go live with the new commercially available system. And then finally, we looked at this post phase, which occurred 3 months down the line, because we wanted to see what was happening well after people practiced with the new EHR and became accustomed to the features of the new EHR. And to do all of this, we shadowed 14 different emergency physicians in each of the 3 phases, and the physicians were not aligned in each of the 3 phases, so we have different participants in each group. And we conducted 2-hour observation periods with each physician in each phase. So we had a fair amount of data here. And in terms of what we actually recorded, we recorded the tasks that physicians were engaging in on a minute-by-minute basis at a very coarse level. So for every minute, we would indicate whether they were working on a computer task, whether they were engaged in verbal communication, whether they were seeing a patient, whether they were working on paper, and we had a couple other categories that actually fell out of our analysis, keeping in mind that, of course, physicians could be working on multiple tasks at any given minute. They could be multitasking. Because we were looking at the 1-minute mark, you could also engage in 2 or 3 or 4 tasks in any given minute by simply switching. So those were the tasks that we were paying attention to and the way we did observations. Next slide. And the first thing we looked at is general task allocation time, which is what you often see in the literature. That is where physicians spending their time across these 3 phases. And on the x-axis here, we have each of the particular tasks: computer, verbal communication, patient room, and paper is the main categories. On the y-axis, we have the percent of time that was spent on each of those categories collapsed across the 14 physicians. And the dark gray bars are the pre-implementation phase, the lighter grays, the go live, and the middle colors post-implementation. So if you look at computer, in general, we're seeing trends that you might sort of expect. When we have that go live period, that first week of new technology, computer time increases substantially, but actually then returns back to normal 3 months down the line. Verbal communication goes up and returns back to normal. Unfortunately, time in the patient room goes down during go live, but comes back 3 months down the line, and a similar trend with paper. So if you were to look at these data alone, you might come to the conclusion that, well, that first week of go live is challenging, as we'd expect, because there's new technology. But look, 3 months down the line, clinicians are growing accustomed, in this case physicians are growing accustomed to the system, and things return to normal. Next slide. Except if you dig a little bit deeper and look at things like how many tasks are physicians engaging in any given minute, we start to see what the cost of the EHR actually is and how it's actually changing work processes. So what we're looking at here are the number of tasks that physicians are engaging in any given minute, with the light gray bars being 1 task, and then increasing to 2 tasks, 3 tasks, and 4 tasks. And what we find is that during the pre-implementation phase, physicians roughly spend 50% of the time doing 1 task, and then the next biggest chunk is doing 2 tasks at any given time. But if you look at post-implementation, 3 months down the line, after they've had some time on the technology, we see a significant increase in the number of tasks physicians engage in. And in particular, we see physicians taking on a big block of 3 tasks more often than they did in the previous 2 phases. Next slide. So we've characterized this as being sort of the cognitive cost of the EHR, and this persists again even 3 months down the line after there's been this time for physicians to grow accustomed to the technology. So we're seeing increased tasks per minute, which means we're seeing increased task switching, and there are tremendous cognitive costs to task switching. If you look to the cognitive literature, the human factors literature, the cognitive science literature, there's an abundance of evidence suggesting that increased task switching results in an increased likelihood of error, but it also results in increased stress and frustration. And so much of that stress and frustration that we see in surveys of physicians and we see physicians voicing is likely driven by these cognitive changes that we're seeing and this increased cognitive burden from task switching. So users are essentially being forced to adapt their work practices to the EHR. Next slide. So that's sort of the frontline piece of this. We've seen the impact in this particular one study, the frontline impact of EHRs and the cognitive cost of it. And now I want to switch to talking about, well, what's happening in the usability landscape and how does that reflect back on what frontline users are experiencing. Now, we all know that health IT usability and EHR usability is incredibly complex. There are several different stakeholders, and we know that we need to take a systems approach to tackling these problems. And the next study that I'm going to present is very much focused on vendors, and it's focused on vendor UC processes as it relates to certification. So I want to quickly cover what the certification requirements are. So the ONC has particular safety enhanced design usability certification requirements in place to promote usable design and development. And that stipulation is really that vendors must attest to a UCD process on 8 key capabilities that have been identified as high-risk capabilities. And for those 8 capabilities, they must conduct a summative usability test and report the results of those tests to the ONC authorized certifying bodies in order to pass the safety enhanced design stipulation. That's what I'm going to focus on in the next study. But I do want to very clearly state that we know this is not, usability is not a vendor-centric problem. There are incredible challenges that arise during implementation. At best, we can describe implementation as fuzzy. There are particular things that certainly vendors can be doing better, in particular guidelines that need to be rolled out. And there's a whole host of things that providers can be doing better. And we've heard stories of providers actually making decisions that undo much of the great work that vendors have done. So implementation is a big piece of this. And equally important is to better understand the provider IT infrastructure that's in place. So we know that much of the rollout and implementation involves significant investment in IT infrastructure, and oftentimes provider IT infrastructure is not quite up to par, resulting in several challenges. So while my next several slides are going to focus on vendor processes, we fully recognize that this is a complete systems problem and there's several stakeholders, and I want folks to keep that in mind. Next slide, please. So I'm going to switch to talking about what we can learn about vendor UCD practices. And we've been doing a fair amount of work in this area. We recently had a paper come out in JAMIA about a week ago describing some work where we visited 11 different EHR vendors to understand their UCD processes and to understand the challenges that they face. And as an add-on to that, we have recently done a pretty significant analysis of the vendor safety enhanced design certification reports that are made publicly available after a product is certified. And we've done a sort of quick analysis of some of that information, and that's what I'm presenting today, and we'll have more in-depth analyses coming out soon. What we did for the study is we looked at the top 50 EHR vendors based off of provider attestation rates. So we went to the CMS website and downloaded information on which vendor products are being attested to, and the period that we focused on was April 1st, 2013 to November 2014, and we looked at attestations based off of the 2014 certification requirements. And we took the top 50 vendors, which those top 50 vendor products accounted for roughly 90% of the attestations during that period. We then pulled those reports from the ONC Chapel site when they were available. They're all supposed to be available. And if a particular product was not available, we went to the next product by the same vendor, assuming that there would be some overlap in the UCD processes employed. And specifically, we focused on the CPOE capability for several reasons. One is it's a high-risk capability that needs to be tested, and two, it's primarily a clinician capability, and so that tells us what the end users should be. And we focused on looking at two things. We looked at what the reported UCD process was, since there's a requirement, a certification requirement that vendors attest to a UCD process and provide a statement of what that is. And then we looked at the number of participants and participant demographics for the participants in the summative usability test for the CPOE capability. Next slide, please. So given that we're focusing on the CPO capability, again, you'd expect clinicians as being the end users, and I'll touch upon that as the next slide. Looking here first at the UCD process employed, shockingly, 34% of the vendors actually did not report the UCD process that they employed. So we don't know if no UCD process was employed or they simply didn't state what it was. Keep in mind that it's a certification requirement. So 34% had no UCD process reported. I should also point out that our intent was to focus on 50 vendors. We were actually only able to analyze 41 vendors. 9 of the vendors did not have their reports made publicly available as they're supposed to be made publicly available. So 34% had no reported process. You can see the breakdown of the other processes that are employed by vendors. The ISO guidelines are the next most commonly employed UCD process, followed by the NIST 7741. 15% of vendors employed their own process and provided a rich description of that, and you can see the breakdown. Next slide, please. Now, looking to the actual test participant demographics, the range of participants in the summative usability test for CPOE was from 4 to 51. And what you're seeing on this graphic here on the x-axis are each of the 41 vendors with the information available. On the y-axis are the number of subjects or participants in the study. And while there's no explicit certification requirement on the number of participants that should be in the summative usability test, NIST guidelines suggest 15 participants, and the FDA also suggests 15 participants. So that's what we've been using as our guideline. And what we found was that several vendors actually ran far less than the 15 participants. 63% of the vendors, in fact, used less than the 15 participants. And in this histogram type chart here, the dark shade represents participants with a clinical background. The light shade represents participants with no clinical background. Given that it's a CPOE capability, we would hope that we're representing the end user demographic. And what we're finding is that several vendors are actually not using very many clinicians in their summative usability test for the CPOE capability. And in fact, only 22% of the vendors used both at least the 15 participant requirement and had 15 participants with a clinical background. So unfortunately, we're seeing some pretty gross violations of the testing standards. Again, these are not certification requirements that are explicitly spelled out, but are pretty common standards. Next slide, please. So I talked about a lot of this, and I know I'm running out of time, but a quick summary of the results. I talked about the 63% and the 22%. Surprisingly, 17% of vendors did not use any physicians. 1 vendor had no clinical experts whatsoever. Keep in mind, all of these products were certified. 5% used vendor employees. And as I mentioned with our previous JAMIA study of visiting several vendors, in that study we found that roughly 1/3 of the vendors we visited had no true UCD process in place, And in this study, we're finding that 34% of the vendors actually don't state a UCD process. Next slide, please. So to wrap things up, I think we know that there's some issues here with the vendor UCD processes. Of course, there's a lot that we can do to support vendors. When we made our vendor visits, one of the things that was clear was that several vendors had trouble recruiting clinical experts for their studies, and that may be what we're seeing in the results that I just presented. And we can do other things like provide rigorous testing scenarios to facilitate the usability processes that are being employed. In addition to that, I think we need to provide clear usability requirements for both vendors, but also for the accredited certification bodies. The fact that these particular vendors are violating the certification requirements and some of the standard testing stipulations is quite troublesome, and I think it's the certification bodies that need to be looking out for that. And finally, I do want to stress that we need to really understand what's happening in implementation, and we also need to be asking ourselves, when we go through the certification process, given all the dramatic changes that occur at implementation, what are we actually certifying? Do some certification requirements, usability testing, need to occur after implementation so that that true product that's touching frontline users has been tested in some fashion? Next slide. I'm going to stop there. Thank you so much. I appreciate everybody's attention and look forward to questions at the end of all three speakers.
Great. Thank you very much, Raj. And let me transition right away now into our next presenter. Chris Engdahl has been a user advocate for over 20 years, has a Master of Science in Human Factors in Information Design from Bentley University, and has conducted research in a number of industries. She's been with Athena Health since 2010. She's seen the user research team there grow from 3 people to over 20 people, and she's led the fulfillment of the Safety Enhanced Design criteria for Athena Clinical's Meaningful Use 2 certification in 2013. Chris's presentation is called It Takes a Village, an Integrated Approach to EHR Advancement. And take it away, Chris.
Thank you, John. And thank you, Raj, for sharing your research. I will suppress the urge to describe all of our summative testing and all of that to say that we're one of the good guys. I'll stop that. For those of you who aren't familiar with Athena Health, we provide cloud-based physician software and services for practice management, and we have an EHR called Athena Clinicals. We also do a lot of work to connect clinicians with each other and with their patients. Like many of you attending, Raj and Ross and I all agree that if anything deserves the best user experience possible, it's healthcare. And yet healthcare user experience has been very far behind that of other industries. So the question is, how can we advance the safety and usability of EHRs, especially if the approaches taken so far have fallen short? So I'm here to present the approach that we take at Athena Health. This is something we've developed over several years, and we think it works. I have with me Tricia Flanagan. She's Senior Manager of Patient Safety at Athena Health. She provides proactive design consultation and reactive support for product improvements, and she's responsible for ongoing educational programs across Athena Health and for supporting government affairs initiatives and activities. Tricia is an RN with an MSN and extensive experience in risk management and clinical care. I'm doing the presenting today, but Tricia is on the call and available to respond to questions later. Next slide. So the integrated approach that we use at Athena has 4 key components. First, an investment in expertise in all aspects of user experience and patient safety. Second, processes that embody effective, repeatable ways to leverage that expertise. Third, the dissemination of that expertise across the organization, resulting in a culture of safety and user advocacy. And fourth, a continual effort to enlist as many users as possible to help make the system as easy and safe to use as we can make it. Next slide. So first, building expertise. There's a common misunderstanding that adding a clinician to your development team or hiring a couple of UX professionals or engaging in consultancy to run a summative test, for example, is enough to make an EHR safe and easy to use. When in reality, to do this, you really need people skilled in several distinct areas, and you need a pretty deep bench. Next slide, please. So, and I want to just distinguish for a moment, because cognitive support and safety are so closely related, it's really tempting to equate safety and usability, but they're really not the same thing. There's obviously more to safety than usability. Consider that there's lots of research on effective practices and policies for ensuring safety. And for example, the SAFER guidelines cover way more than just EHR use and design. Likewise, given that standard definition that Raj talked about earlier, safety is only part of usability. It's really embodied in that effectiveness measure. So in order for anything to be effective, you need to be able to accomplish the intended tasks safely. Some safety measures are really there to slow the clinician down and help them to pay really close attention to a particularly risky task, and that does affect efficiency. And because we know that healthcare professionals are really busy and they value efficiency extremely much, it's really important to them, anything that affects efficiency is going to detract from the satisfaction component of usability. Next slide. So, to advance the usability and safety of an EHR, you need a lot of different kinds of expertise. Sometimes I'm asked by a physician or a nurse, how many clinicians do you have on your development team? And I can see where they're coming from. I'm certain they've been working with something and thought, whoever built this never worked on a unit, or whoever built this has probably never even been to the doctor's office. Why don't they have a clinician on their design team? And, I totally get that. You want to make sure that the user's point of view and their working habits and their goals, that gets built into the EHR. But having a clinician on the staff is not going to do it. I've had doctors tell us things like, everything should be in a drop-down. What they mean is, I really want this to be fast, and I want to recognize the value that I want to put in rather than having it to recall it from my memory and type it in. Or they'll say, this needs to be red text on a yellow background, which really means I really need to be able to see this and not have to hunt for it. So that's the clinical expertise, but the design expertise is really different. Skilled designers can come up with dozens of ways to make a task really fast and to support recognition over recall. Drop-downs might not be the best way in all cases. And designers know how to make an important information stand out when it's needed and take into account everything else that needs to happen on that page. So instead of having clinicians trying to do design, focus them on patient safety. This discipline combines clinical and risk management expertise to ensure that what gets developed can be used safely and also promotes safe practice. User researchers are skilled in unbiased observation, data analysis, and usability evaluation. So you want to have them observe and test with multiple representative users to get a range of perspectives. I already talked about the designers. Copy people are focused on the language and labeling in the EHR. They apply their expertise in human communication to ensure that all the language is clear and concise and consistent. Obviously, people can be skilled in more than one area. We all know designers who can do user research and people who are good at communication and other things. We all know there are doctors and nurses who have really good design instincts. My point here is that for any of these areas of expertise, the more you practice and develop that specialized skill, the more effective you become. And to tackle the challenges of usability and safety in an EHR, you really need the deepest knowledge you can get across the spectrum of expertise. Next slide, please. So what might that look like? What it looks like here is the user experience team is part of the research and development organization, which also has product innovation. That's a unique term for us, but for the sake of simplicity, it's a combination of business analysis and product management with a little bit of cat herding thrown in, and then development. So we're part of that organization. The UX team here has user experience design, user research, copy, and patient safety, as I just described. Right now, we're above 80 people in the team, and about 45 or so of those are working directly on our products that are related to clinical care. In addition, over the last several years, we've developed a cross-functional team that is completely dedicated to patient safety. So this team includes clinicians, as well as designers, researchers, copywriters, product innovators, and developers. And they're all dedicated to ensuring that the safety-centered design principles are adhered to throughout the development process. This team also evaluates and responds to potential safety issues discovered internally or reported by clients. Next slide, please. So you get a big group of people, and what are you going to do with that expertise? Next slide, please. Thank you. So having a good group of people is a start, but if you have them in a room by themselves and nobody listens to them, or their voice isn't actually built into the development process, you're going to have a problem. Next slide. And I will apologize for the complexity of this slide. Raj's was much cleaner, but bear with me for just a moment. This is an alternate view of a user-centered design process, like the diagram that Raj showed earlier. This diagram starts, so this process of user-centered design starts in the upper left-hand corner with the context of use. Understanding the context of use helps inform requirements. And once those are clear, there is design, which is then evaluated either in a paper prototype or a clickable prototype, or sometimes if you scoot around the edge of that little racetrack, it might be implemented, and then we might evaluate the early implementation, early code. Evaluations often reveal more about the user's context. It may show more requirements, and it pretty often results in iterations on the design. So after this process, then there's implementation, which again, you can reevaluate if needed, and eventually the process results in the release of the product or feature enhancements, which then you can observe and measure the effect of. So Athena is a cloud-based company, so a lot of our observation and measurement is of actual client performance. So for example, we have we grade ourselves on the amount of time it takes for an ambulatory physician to document an encounter. So we take an average of what everybody's taking. And we have a goal, and that's our goal for the user's performance. The little colored text boxes in this diagram show the different kinds of activities that the different roles do in this process. So for example, to find out more about the user's context, researchers will conduct field studies, will go on site and observe, we'll conduct interviews either on site or remotely. We might do surveys. There's a bunch of things we can do. As the requirements and the context of use become more clear, designers spend a lot of time, they're in the little blue bubble, they spend a lot of time figuring out lots of ways to solve the design problems that are in front of them. They'll attend these user research activities and iterate on the design as needed. And meanwhile, in the yellow, the patient safety team will be reviewing literature that's related to the project. They'll assess risk potential, review designs as they're developed, and observe usability tests. So I'm not going to go through the whole thing, but you can kind of see this is built in. This doesn't include all the roles. Copy does things pretty much on the same timeline as design, only they're focused on words rather than the larger pictures and workflows and widgets and information architecture. And then product innovation is involved in all of this. They are responsible for the definition and the scoping of requirements and driving this process. And development also is obviously involved in the whole process. They are primarily responsible for implementation and release. Next slide. So that's how our design process works, and this is actually a slide that we had in our description for the user-centered design requirement for the standards. So if you have a great team and you're putting them to use, that's great. There's still more you can do, and this picture that you're seeing it's a picture of one of our workplaces. So this is what our workplace is like. I don't know where everybody is. I think it's early in the morning or they're all in meetings, but this is what it looks like here. Next slide. Once you have a good team and you're putting them to use, you still can share that expertise across the organization so that everyone involved in product development is a user advocate and a guardian of patient safety. So you remember that picture. That's what our workplace looks like. It's very unlike the clinics and hospitals that our users are working in. So one of the things we do is we pretty much make all of our research and development employees visit a client site and observe sometime in their first 90 days of employment. This helps build empathy for the user, and it brings home the truth that you are not the user. They're not the same thing. New employees also receive training in patient safety, so they know when they are touching areas of potential risk, and they understand key principles of the safety in EHRs. Trish's team presents the SAFER guidelines and identifies those risk areas, and they present guidance on when and how to get the patient safety team involved in a project. All employees here are expected to look out for any potential safety risks and to report them to the patient safety team. And the team then reviews each report and evaluates the risk and determines the best response to the report. On the usability and user experience side, within these cross-functional teams that are doing the projects, all the roles are involved in the user research activities. So PIs and developers, designers all contribute to the user research plans and the goals of a research study. When we have field studies, we like to start by going off and seeing how people do things now. When we do that, all the roles participate in those studies so they can all see what the users are doing. And then when we have a formative usability test, all of the disciplines observe those sessions. We have a really high attendance rate for those things. Next slide. Another thing we do is after we've done a study and we've analyzed the results, we present our findings to the teams, and those findings include instruction on different user experience principles. So for example, in this study, the users experienced change blindness. So this talks a little bit about that UX principle so that people can learn more. Next slide. Patient safety education also occurs on an ongoing basis. Sometimes teams will request research on a particular topic, or often the patient safety team will offer presentations of topics based on their literature review. These ongoing presentations, along with the project-specific patient safety reviews and consults, empower all of R&D to look out for potential safety risks and to know what to do when they identify a risk. Next slide. So, say you've enlisted your entire R&D organization, you've got this set. Is there anything more you can do? Well, yes. There's a huge army of people out there who are the real experts in user needs and expectations, and they are on the front lines of any potential safety risks. They are your users. Get as many of them as possible to help you. Next slide. We at Athena are always looking for ways to engage our users, both to look out for potential safety risks and to help us bring that user voice and the user perspective into our development process. We have user forums where all users can discuss what works and what doesn't work about what they're interacting with, and we do monitor those. Contact with support to report product issues or usability issues or safety issues is accessible within our application. We try to make that as easy as possible to get to. Users can talk to their account managers and they'll direct their issues to the proper team. Also at user conferences, we try to do as many user research activities as we can, and then we recruit users through that way to participate in further studies. And we're constantly looking to build our pool of user research participants. We ask them to let us visit them at their hospitals and clinics. We invite them to spend 30 minutes at a time with us through an online meeting for interviews or usability tests or focus groups or whatever we can get. We also conduct surveys and unmoderated studies to get as many users as possible to spend 5 or 10 or 15 minutes with us. They can do that at their leisure, and then we can use that data to inform our designs. So far, in 2015, we've done over 160 research activities. We are not done at all. We've got a lot of work to do, and we're continually working to try to improve all of this. Next slide. So that's a description of our process. We believe that this robust process that integrates both patient safety and all the different aspects of user experience, this robust process, rather than any individual practice or a single usability test, is what's really needed to advance the safety and usability of any EHR. This is not a proprietary process at all, and it's not really rocket science. It's an investment. We've been working on this for about 7 years, but it's an investment that we believe is worth it. Thank you.
Great. This is Jonathan Wald again. Chris, thank you very much for your presentation. And again, we will be taking questions after the last of the 3 presentations. So I want to go ahead and introduce Dr. Ross Teague. Dr. Teague is the manager of the User Experience Organization at Allscripts. He has led that effort within Allscripts to create a user-centered design process that many teams in the organization can follow. He's also the chair of the EHRA, the Electronic Health Records Association UCD Best Practices Work Group. He's been involved with and leading research and design efforts for medical devices and healthcare software for more than a decade. And he's also worked in product design as a strategy consultant in other areas, consumer, industrial, and commercial products, Intel as a human factors engineer, and has a PhD in human factors and applied cognitive psychology. Ross will be presenting on do standard UCD methods apply in healthcare. On to you, Ross.
Thank you very much, and I appreciate the forum today. So what I want to talk about is the application of user-centered design methods to healthcare, but not in terms of techniques or the steps, but whether the standard methods that we use work in healthcare. And so even if you're like me and you've been working in healthcare product design for a long time, or feel that you've been seeing good success in your current usage of user-centered design methods, I hope that what's presented today and we discuss will challenge your approach and your view and your thoughts about HIT design. So let's go to the next slide, please. So the ideas for this presentation came about through a lot of discussion and arguing and just some good fun discussions with people. And so I'd say thanks to a lot of the folks that you see on here. So let's go on to the next screen. So I want to start by just quickly setting the stage for this discussion. Both Chris and Raj talked a lot about this and set a nice foundation for this, but we'll just assume that we all agree that usability is something that's important to address related to healthcare technology, and efficiency and safety and satisfaction and quality of care are all reasons for doing that. And lots of people agree that. There's lots of government folks and other people that have been putting forth guidelines and so forth, and even the Congress cares about it. Tuesday there were the EHR user experience sessions, and they were talking a lot about usability of these products. And so what do we do to address usability of a product? Well, Chris and Raj talked about that. Next slide, please. There's a process for that. It's called user-centered design, right? And so this is a diagram of one, and Chris and Raj show diagrams of others. And go ahead to the next screen. So a lot of companies are following these processes. And if you think about it, at least 66% of them, according to Raj's data. But a lot of HIT companies are following these processes. But this is what we continue to see, and we continue to hear. And so this is just a quick review of the web from the last couple of weeks that I did. And to be polite, I blacked out the names of the different companies that were mentioned up here. But all of the big names are represented. And the question that I start really looking at from this is if vendors have these UCD processes in place, what's going on? And so let's go on to the next slide here. There's lots of reasons that we can probably assume that HIT usability hasn't reached the place that our users and we would expect it to be. I mean, Raj's data that he talked about suggested that there's a number of companies that may not even be employing user-centered design processes, and that certainly can impact usability. But that's not what I want to focus on here. I want to focus on what about companies that are employing these UCD processes. What's causing usability not to be as much as we want it to be? And it can be any of these things, right? It can be regulatory, what they're requiring. It can be the billing requirements that organizations put on themselves. It can relate to the deployment and customization by users. It can also be not considering, and Raj talked about this, consideration of the cognitive loads. These are these hidden sort of things that we don't always see. And they all deserve some blame. They do. All of these types of things that you see here and others deserve blame and will need to be addressed as far as usability goes. Let's go to the next slide here. But what?
Raj,
yes.
This is John. If you can improve your voice quality, that would be great. It's okay, but it looks like it feels like it could be a little better.
Sorry. Okay, good. I'll try to lean into this a little more.
Thank you.
And so I guess the question that I've started to really look at here is, what about the user-centered design processes themselves? Do we as designers and developers assume that user-centered design is the answer for solving all these usability problems that we continue to see? Or is it maybe that if we do more of it, that it'll make everything sort of better and we'll resolve all these usability issues? And so, is it maybe just that are we assuming that the methods that we've used in the past or we've seen used in other domains will lead to the same positive results in healthcare? And so that's what I want to talk about is how healthcare is different today, but more importantly, how it can impact the user-centered design methods that we choose and how we apply them. And so I don't have enough time to go through all the differences that I've thought of, and you probably can think of yourself, but I've got 3 that I want to discuss today. And the first 2 I'm going to try to go through a little more quickly. So let's go to the next slide, please. So did anyone see this article from the Wall Street Journal? I think it was interesting because it describes how this article describes how a user of a blender, a chef, was so frustrated with her experience with this blender, and she just didn't feel like the blender manufacturer knew enough about how to build one that really met her needs. That instead of just sending in writing a blog post or an email or just going and buying another one, she took the time to work with an engineer or the designer to come up with this guide for how to better build how to make a better blender. And she made this available to the manufacturer and all the other manufacturers that were out there. If you don't remember seeing this, that's okay, don't worry, because this story is a fake. I made this up just to try to illustrate a point here. We would never really think of a blender customer or some other type of, I had trouble thinking of any other type of customer that would do something like this. They might complain or send a letter or blog about it, but they most likely would just move on and buy another product. But they wouldn't spend the time to create this in-depth guide and publish it and get it out there and do all these kinds of things. And so I couldn't think of any other types of users who would do that, next slide, except in healthcare. And that's one of the ways that healthcare is so different from other domains and other users, and I think it has to be really understood and really considered. And I hope you all have seen Dr. Jeff Belden's ebook on EHR Usability and Design. He saw a need, he cared enough about it, he's got deep understanding in the space, and he worked with some experts in design and human factors and created this freely available ebook. Now, be careful that you don't miss my point. This isn't a complaint. I think it's a great resource. But if we're not seeing this kind of thing happen in other user groups, so, in different types of products outside of healthcare, what's going on? Why did it happen here? And, why are so many clinicians so interested in, they're getting informatics degrees and they want to be involved in the details of all this. What is it about this type of user that is different? And, it's several things, right? So the impact that these products that they use has on terms of safety is a key. And so they really care about it. They want these things to work really well. It's life and death that's going on here. But it also has a very direct impact on them and their well-being and their families. And also, they just can't easily walk away like they could if they didn't like their blender or they didn't like their smartphone. They could try another and just walk away. They can't do that with the products that they have very easily. And so we could view this as being sort of evidence that user-centered design, people at the, EHR and HIT vendor firms just aren't doing things right. Or you could view this as evidence that, no, these are different sorts of users and we need to involve them in this. And so I think it's sort of a little bit of both. I think it's more of the latter in the sense that we really need this kind of input into what we're doing because healthcare is such a unique space. And next slide. We have to really start by understanding that our users in this healthcare space are different, and we need to adapt our user-centered design methods accordingly. And so here's a list of a lot of things that make them different. You could create your own list and have that yourself, but it's really the collection of these, not one or two that make them different. It's this collection of these, and a lot of them are very, very obvious, but there's some that are very concerning or I think have a lot of impact on the methods that we use to collect and involve these users. For example, Dr. Schlossman from the Missouri Cancer Associates, he was talking to me. I saw him at a conference, and he's been trying to run his own usability tests with their products, and even he's been finding it difficult to schedule people. These people own his own staff because of how busy their schedules are, the cost that that not seeing patient costs them money, and perhaps most concerning, they don't feel like their comments matter. And I see this kind of a growing problem in a lot of this because of the way that their comments are heard and how do they actually see benefit and value from that. And I have on here this idea that our users are different because they're harder to empathize with. It's not because we don't like them, we don't care about what they're doing, but empathy can be difficult because so many people that are designing these products don't have clinical backgrounds. It doesn't mean that we can't create great designs, but to do this must come about through very intentional collaboration with clinicians within our organizations, outside of organizations. So I think if we can agree that clinical users have their own characteristics, that's fine. But the question and the challenge that I have for folks listening today is, how do we take advantage of these positive differences? These users of ours are smart. They want so badly to be engaged. They really care about these things. But maybe even more importantly, how do we manage the negatives? The fact that they're time burdened, that they have been sort of led to feel like their voices aren't listened to as a whole because the changes are so slow in coming or don't happen. And many times these users are not the purchaser. How do we deal with those kinds of things? And so I think that's really the first piece I wanted to talk about, is that we miss out on the benefits of some of the user-centered design benefits. We treat these users like they're users that we found in other domains where user-centered design is typically run. So let's go to the next slide. The next big difference, and I don't want to spend a lot of time on this one, but I think it's important, and Chris talked a little bit about it in terms of the level of rigor and approach that they apply to their projects, is the big difference is the amount of, I think, the rigor and attention to detail and user-centered design processes that's required in healthcare. In the majority, let's just be all honest with each other here. In the majority of other fields where user-centered design is applied, you can be a little more sloppy with it. You can get away with it. And how do I know that? Well, I've had to do it. When I was working in a design consultancy, non-healthcare related products, I've been really busy and juggling different projects and tight timelines and so forth, and I've had to take shortcuts in the user-centered design process. And you know what? It still worked out. We came up with a great product that met user needs, helped the business that we were working for sort of do the things that they wanted to do. But in healthcare, taking shortcuts is more likely or will lead to poor user experiences. I think we're seeing that. User-centered design processes will tell you how to collect data and methods to follow, but doesn't tell you how to extract meaning from the data. And again, in other fields, you can sort of grab some nuggets from some research and make a difference. But in healthcare, it's a requirement to dig deeper, to spend more time doing that, understand more than just what you see or hear. And this takes expertise, it takes collaboration, but it also takes time and money to do that right. This rigor can't be centralized in a design team. Chris gave a good description of this earlier when she talked about spreading the expertise. I think that's really important. Another factor related to rigor in user-centered design methods in healthcare, and it's a place that I've seen corners typically get cut many times that other domains can absorb these, but it's related to the documentation of the user-centered design process. And why is that important? Well, first, for some groups, when you have a requirement that you're going to document everything that you do, then you know that it's actually going to have to get done. But for others, it allows you to get people in your organization up to speed on who your users are, their tasks, what they've said, and documenting all of your user testing, including the simple formative studies, helps you to go back to a clinician or to a team or a group and say, look, we heard this, or you told us X, Y, and Z the last time that we were here, and here's how we use that, or here's what we can and here's what we can't do. Helps them feel like their voices really matter as a part of that. And finally, there's a matter of pride that I found gets in the way of the depth and rigor that we apply in this effort. We need people who understand more than we do about the domain heavily involved. And I've had to deal with this. I'm sure others have as well. Designers can be super skilled at design and research, but we need collaboration with clinicians. We need to help them help us interpret what we're seeing and what we're hearing in terms of research. And I know we all have clinicians on staff and our teams, and we think we involve them in the best way possible. But do we really put them to the best use? I mean, we assume that we do, but from my conversations with other user-centered design practitioners and clinicians, this is a huge opportunity for improvement. And so my challenge to everyone today is to stop and look at how you're doing this. Just assess it. How are we getting as much out of this? How are we digging as deep as we possibly can? And how are we really applying these methods in the appropriate way? So let's go to the next slide. The final topic that I want to cover relates to complex socio-technical systems. And some of you may have heard about this topic before, some maybe not, but be careful either way. Don't dismiss this as, yeah, Ross, we know healthcare is complex. Come on, what else? That's not different. What are you going to tell us? And that while that's true, understanding complex socio-technical systems is important for what it means to user-centered design and to usability. And so a definition of complex socio-technical systems is they're high, I'm kind of reading this, so they're high impact, difficult to understand, technology intensive systems that have major societal, political, and economic implications. Well, it sounds like healthcare. You can see many of the aspects of complex socio-technical systems listed out here. For some of you who are still unfamiliar with what this topic is, so examples of complex socio-technical systems might be like transportation networks in a city, or national security, or a nuclear power plant, things like that. And it's important to recognize these elements of what makes a complex socio-technical system, things like the social aspects needing to be considered, or the uncertainty of data that's involved in the system, and the fact that an environment continues to change once a new technology has been added to it. Those are vitally important to how we design, and each one of those we could do its own presentation and discussion about. But there's another perspective on complex socio-technical systems that is really important that I want to bring up. Let's go to the next slide. There's a quote from Blodowski-Berger that I've been thinking a lot about, and that's what's listed here, and what it means to user-centered design methods. He says, in summary, that in designing for a complex socio-technical system, the best that we can do is good enough. We must focus on satisficing, his word, instead of optimizing. And now, why is this? Because in a complex socio-technical system, you're not designing for a user, but a system of them. And typically when we think about the term user-centered design, as the name applies, it puts the emphasis on a user, but it's typically a user. But in complex socio-technical systems, that's a very narrow focus, and that may not be appropriate. And it impacts the amount of influence that following a user-centered design process can have on solving the usability of a particular product. And I'm going to talk a little bit more about that. So let me drive this point home with a simple visual for those who, like me, like to learn visually. Let's go to the next slide. Since a nuclear power plant is often used as an example of a complex socio-technical system. I'm using that term meltdown as being a really terrible experience. That's kind of what's here there in the middle. And it applies across any complex socio-technical system. Think about that as this is the space that we do not want to go. In terms of health IT, we would really like to optimize that outer ring for all the stakeholders that are represented. So you go to the next slide if you would. So that means, you know, we want to have billing and regulatory and IT and safety and doctors and quality and nurses and patients and so forth. We want to optimize for them because that's how we think as designers, and that's how we think as vendors. We want to, you know, optimize for that. And we want our people to be happy. We want for everyone to feel like that a system was optimized and designed for them. But complex socio-technical systems would tell you that that's not possible in a system like this. And what we can hope to achieve, go to the next slide, is an acceptable balance of all the stakeholders' experiences. Now, some of you are feeling maybe a little strange about this. You're saying, well, that's not, I'm a designer or I'm a marketing person. I don't typically like to think about that you're telling me that I should just design for just good enough. I want to focus on optimizing for users. We want people to feel really good about that. And so what we want to optimize for is we say, we have to optimize for a group of people. We really need to do this. So we really need a certain part of the system. Go to the next slide. But when we do this, we say, all right, let's look. If doctors don't get paid, there's no, we got to focus on billing. We got to make sure that happens. And let's go to the next slide. So we focus on billing. We want to optimize for that. But when we do that in a complex socio-technical system, we end up moving others into the meltdown area that we want to avoid. Now, clinicians, maybe some are on the call, would probably say, well, that's where I am now. With these EHRs, I'm in a meltdown mode right now because we've tried to optimize for some of the other stakeholders like billing or admin or regulatory, and that's likely true in many cases, and I've heard many people say that. But according to the complex socio-technical systems theory, we've got to be very careful not to shift others into this meltdown mode. And achieving this balance requires a lot more than just a user-centered design approach. And we have to not rely on human adaptability, and as Raj talked about, realize that there are these hidden cognitive loads associated with the decisions that we make. So what can we do to improve? For example, let's take clinicians' experience. What can we do to improve a clinician's experience of a lot of these EHR products? Well, we can say, well, we're going to optimize for them. Okay, we're just going to optimize for them. And that would be a change, but we need to recognize that will come at the expense in other areas. And another option is to reset what we consider acceptable. But this has to include all stakeholders, not just one or two, where we say, look, you gotta deal with good enough here. Everyone in the system has to understand that. And another option is to look at the system itself and change the roles that people play in that system or the expectations that they have about those different roles. Why is it that we made the leap from doctors years ago jotting down a few notes while meeting with a patient to expecting that they could record more details and do the billing, administrative, and things like that? How can we involve other roles in this, patients in this, automation? How can we do some of that? So let's go to the next slide. I have time here for a quick story. My brother, next slide please if you would. My brother is a judge, and I was talking to him, and I asked him what it would be like if he had to take notes while officiating in court, because I was thinking about these doctors having to do similar things. And I said, because this could save money. You don't have to have the court stenographers, and you're sitting there, and you're engaged. Why don't you just take notes while the court's going on? And here's what he told me, and I've paraphrased a little bit, but I'm going to read it. He said, well, that would take away too much of my attention. I have to listen, not just hear. I have to make decisions that will impact people's lives in significant ways. I have to manage multiple people who are coming in and out of the environment. I have to watch body language. And the number of cases I sit on some days is so many I would never be able to complete the notes accurately. I would miss so many important details that when someone else looks at the transcripts, they wouldn't know what happened. Does that sound like any other profession that we know of? Let's go to the next slide. Now, so the question is, does that mean we need to start thinking about scribes? Well, maybe in some instances, but of course we have to consider that comes at a cost. But we also have to think about the burdens that we put on clinicians now and the costs associated with that. in terms of dollars, in terms of safety and accuracy, satisfaction, outcomes, and things like that. If we're not really looking at this with a complex socio-technical system perspective. Maybe it's just a matter of trying not to optimize for other stakeholders at the expense of clinicians. And maybe it's also working within the system that others can understand and be willing to take acceptable and what that means for them to keep all of the system working together, not in a meltdown particular mode. Let's go to the next slide. I have time for one quick consideration that I wanted to make sure I had time to include here. I'll do that very quickly. And this is another illustration of how different healthcare HIT, specifically EHRs, is and makes the application of user-centered design different from other fields. So what I want to do is I want to show you some screenshots of the leading EHRs that are out there and how each one of them handles a couple of different critical tasks, all right? And it'll highlight best practices and illustrate where there truly is a need for usability and who gets it right and who doesn't, okay? Next slide. So did I get anyone excited or nervous maybe? I would really be excited if I could see something like that, and I don't blame you if you would too. In every other field I've ever worked in, from consumer products, commercial, agricultural, equipment, entertainment, and so on, I've been able to benchmark my product against other products and know where we're better, worse, or on par. I've been able to set my measurable performance goals against our competition and improve the overall usability of our products as a result. Not in EHRs, not in healthcare information technology. Access to competitive products isn't available, and this is a whole different discussion, I know, but I had a minute here. I wanted to kind of include that in at the end here, but it has a huge impact on design and usability, and it's something that fits into most applications of user-centered design. All right, last slide here. This was just scratching the surface for what makes healthcare different and how our standard user-centered design methods can be adapted and augmented and have value. And so if we go back to our initial question of, do standard user-centered design methods apply to healthcare? Go to the next slide. I hope you would agree with me that the answer to that question is no. The standard methods and approaches that might work very well in other fields won't give us the same value in healthcare without some specific adaptations. And I think understanding how healthcare is different helps us and make those kinds of adaptations. And so summarizing what some of these ideas are, I mean, we realize that if we don't step up the rigor with these methods, that we will limit the effectiveness and potentially mislead ourselves. The other thing that's really important, and this is the village that Chris talked about, is getting more people in your organization capable of following a UCD process. You're not going to try to make everyone into experts, but giving people a good mindset and some tools they need can help them deal with these issues that they have when they come up and just be more mindful of those things. We need to better leverage our smart, opinionated, passionate users and help them communicate that information. And I'm not the first to say this, that in the world of user experience and user-centered design, humility is key, but in the healthcare space, it's vitally important, leveraging these clinicians that we have on staff. Don't just assume that the same observational and interpretation skills that we've been using in other domains will work as well in healthcare without that knowledge. Following your product once it's launched, you aren't finished there when it's launched. You have to understand that putting that product into a socio-technical system is going to make environmental changes, sometimes extremely significantly. And probably most importantly, when you think about where you're trying to optimize for, think about where you might be trying to optimize for one stakeholder and what that causes to happen to other stakeholders. This may not be solvable only at a vendor level. It may require change at a higher level. User-centered design methods are necessary, but they're not sufficient for addressing the usability issues that we're seeing in healthcare IT. And there's a battle, there's a struggle going on that many people who are trying to manage usability and improve the usability of products are dealing with. And what that is that we're looking to apply user-centered design methods to solve usability problems. And that's great, and it can certainly help with that. But in these complex socio-technical systems where we live, where if one or two stakeholders are being optimized for, we're putting others into that sort of meltdown zone, into that suffer zone, and no amount of user-centered design can pull them out of that. So we have to be careful that we're not optimizing for stakeholders. We first need to identify where we are doing that and then figure out how to work our way around that and think about this as an entire system. And so I hope that I've provided you some new perspectives, some things to think about here. And as I said before, there are lots of reasons that usability of a HIT product can suffer. We talked about a lot of what those were, but what I'd like to do is I'd like to make sure that the user-centered design methods that we're using aren't contributing to those problems and that we're applying them appropriately. Next slide. So thank you, and I think this is where it opens it up back to Michael for questions from everyone.
Great, thank you very much, Ross and Chris and Raj. We have a few minutes now for questions and answers, and please put questions into the question box so that we can see them and then we can share them with presenters. And we've already gotten some, but while you're doing that, I just wanted to point out on the last slide, we've got some contact information for the 3 speakers. Our next webinar will be the week of, well, I guess it's about July 19th. We think it'll be on the 23rd, but we'll be solidifying the date over the next couple of days. It'll be on EHR documentation and health IT safety. And also, many folks have asked if they can get copies of the slides, and I just wanted to reiterate that if you go to the www.healthitsafety.org website, click on the Education tab, you'll get links to slides from this webinar, audio, as soon as we post it in a few days, as well as prior sessions that we've had in this series. So now I'd like to go to some of the questions that we've gotten, and those were, I mean, each, I just want to thank you again. Each of those were very stimulating presentations. Going back to Raj, and on slide 14, I think that was where we saw data from the study where you looked at where people spent their time before and after implementation, soon after and then much later. And one of the questions said, so the conclusion is that the new computer system did not really benefit time with patients, time with communications, and so on. And on the other hand, it shows that multitasking is increased. And I'm going to add to that and say, when you see that multitasking is increased, does that suggest more productivity, or does that suggest more cognitive strain? So it sounds like we'd like to know a little bit more, and wondered if you can comment.
Sure, I'm happy to. So yeah, the task allocation time slide, what we found is if you compare pre-implementation, before the system went live, to post-implementation, 3 months down the line, we're seeing no significant differences in any of the task allocation time measures across computer, verbal communication, patient room, and paper. So we're not seeing any differences in time. Where, as you stated, we are seeing differences is in task switching, task load, sort of whatever your preferred method is of describing that. And that, I believe, is not related to, it's not, the finding that we're seeing higher task switching, more tasks per minute, is not because of increased productivity. We've looked at, several different proxy measures of productivity. There's lots of them out there, and we're not seeing differences in productivity. So it certainly tends to be a compensating for some kind of shortcoming within the EHR. And unfortunately, that's where we have to stop. Because we focused on such coarse level of tasks for the study, we don't quite have enough information to say specifically what's happening, and that's really what our next step is. So we've identified this cognitive cost of increased task switching, and now it's a matter of, well, why? Well, what are those shortcomings, and under what particular conditions are these happening, and how can we alleviate that?
Great. Thank you very much. So the next question was also asked early on, so I think it was during your presentation, Raj. But we can get responses from any of the panelists. The question is, can the design drive and improve the cognitive tasks, is how users do it now necessarily the best way?
I'll answer that. Yes, design can drive cognitive support. Good design can do that. And no, the way people are currently doing it may not be the best way, but it does inform how if you're going to change the way people are going to do it, even if it's going to be better, they're going to start from where they are now. So your prior knowledge counts. What are they going to expect can predict how they're going to respond to a new design. Obviously, you can change behavior with design, but that takes a lot of knowledge and a lot of skill. Does that help?
Great. No, thank you. And any other comments?
This is Ross. I agree. I think we have to leverage people's familiarity, but many times I talk to people and I say, I'm going to leverage what you're familiar with, but I'm not going to design for it, because exactly people are using methods or processes that were based on paper. It was based on something else, and we're trying to do something new. And so many times for us, it requires showing them that it's less clicks, or it's faster, or it's in some way allows them to do something with more accuracy. And so as Chris mentioned, you can't ignore that familiarity, because it's where they start from. It's what people fall back on and rely on, and you have to take it. You can build that into that. You just have to be sensitive to that and communicate with that in mind.
Great. So the next question is, and this is for Dr. Teague. I'll just read it. It says, in my world, users involved in the designing of our new anticipated EHR system are looking forward to optimization before go live has even begun. When designing, how can we develop a culture of satisficing, as you have discussed in your presentation?
So a lot of it, I think people have to understand, is that when we think about comparing what does it mean to optimize versus what does it mean to be good enough. Good enough usually sounds like, well, I'm not really happy with this, but I'll take it. That's not necessarily what it means, because it means that people can see the benefits of what they're doing, and over time they recognize that. What it's more important of is getting people out of the meltdown area. It's having people to have specific goals in mind. What are your goals for the product? If my goal is to do this faster than I'm currently doing it, that's great. Let's make that a particular goal. I'm not going to say that I should be able to do this instantly if that doesn't fit the user's need, or it doesn't. That's a way of thinking about optimization. It's sort of what are my goals? What am I trying to do? And the biggest thing that I've found with this is the problem is not how to make something good enough, meaning people are satisfied with it. I think of it that way, is I'm satisfied with this. The biggest problem is not how to do that, and these user-centered design methods can help tremendously do that. The biggest issue is not trying to do that with an anchor around your neck, because something else has been optimized for. And so instead of sort of trying to figure out, well, how do I give somebody just good enough, I try to focus on where are we optimizing for other folks that are putting people into the meltdown area. Because no matter what I do in terms of user-centered design, user input, and user testing, if I've got other groups that are being optimized for, then I'm always going to struggle to even get them into that satisfied area.
Great, thank you. Okay, so we have another question. It says, several of the presenters' slides showed useful-looking process diagrams. How would we request the evidence or the evidentiary basis for those? So if we present those to our organizations as reference materials, we have some further basis for doing that.
So I will start. So a lot of these, so the example that were in my slides, that was a NIST example. I'm not sure, I don't remember where Raj's came from, but I know the group that he talked about earlier that had the, I think his was, his was an ISO example of that, and that was one of the ones that came across most often as people listing that in their certification documents. Around those, both of those have a lot of evidence around that that you could draw on, and descriptions of that and so forth. Chris, you can talk about yours, but I know that Chris is, as she said before, it's not proprietary, and it's built on, hers and many other groups are built on these similar sorts of processes. So even if there's some tweaks to those kinds of things, you can look back at what's in ISO, you can look back at the NIST as well as several others, and they have supporting information around them.
Yeah, I think our diagram is an adaptation of the one from the UXPA site. They have a user-centered design process there. I think, Ross, you have, you actually had links in your slide to the FDA. There was a thing where you had 3 links at the bottom of the page. I think I would ask people to go there. And then Raj, you had the slide that had the different user-centered design processes that vendors reported being on. Any of those you could look up, and those are all well supported by evidence.
So I'd like to ask a question of, well, probably all 3, which is, every company and homegrown efforts experiences a kind of limitation of the resources they have to focus on usability. Can you offer ideas about how you choose where to put your emphasis? And related to that is, how much effort does it take? How do we know that a company has enough resources focused on usability as they develop complex products, or not enough?
Who do you want to go first?
Yeah, pick one.
Okay. Well, Chris, why don't you go first, if that's okay?
Where to put the effort? It's weird. We've got 23 researchers here, and we are still doing triage all the time. We have way more requests for research than we can possibly meet. So we have to do that all the time. In the group that I'm in, we are choosing to spend our research dollars more than even the design dollars, but the research dollars on high-risk areas. So CPOE, MedRec, med administration. So anything that has to do with medication, we're doing that first. You can also, the other things that come into play are, who at the top is worried about something, and when something is needed, and what other resources you have for finding out what will work and what will not work. So there's a bunch of things that go into the tumbler to find out which things are going to get worked on first, but we are constantly working at the highest priority we can to do the best research we can and to do it all the time. Yeah, and we're looking at what is the most risk, what has the most potential risk for patient safety. So we get that from our patient safety team. How to know if your group has enough? If you're looking at a vendor, I can guarantee you they don't. None of us has enough. But if you're looking to find out how much your vendor has invested in making sure that they're thinking about users, I would ask them what processes they have to get user feedback and to get user input, and what your opportunities are to help your vendor understand you. Because I think that's a good gauge of how much they're investing in that. Ross, what do you think?
Thank you. Listen, we're at the top of the hour, so I want to invite Raj and Ross to add, if you have something to add, but let's keep it quick if possible.
I was just going to say, if you're trying to apply your limited resources, and the fact that your resources are limited, that's a whole different discussion around, what's important in an organization, that sort of thing. But if you have a limited set of resources, put them towards, and you're looking at the user design process, for example, put them towards formative testing. which is getting your early ideas, your early designs, getting them into the hands of users so they can provide feedback early so that you can make changes quicker.
Great. And Raj?
I'll just add two quick things. One, I completely agree with what Chris and Ross said. And if your question was about how do we look at vendors and understand their processes and try and make some comparisons, just as Ross said, I think there's an importance to focus on the formative testing component. And if you're a purchaser and you're interested, ask to see the byproducts of their formative testing. Because if they're actually doing formative testing, there should be some evidence of that, and they should be willing to share if they're actually doing it. And the second piece I'll add, which touches upon this thing about resources, relating to the Bin 2 piece of really studying workflow and developing that deep understanding, it's incredibly difficult to do that and takes tremendous investment. And we're never going to get it right if we continue down the path that we're on, where each vendor is trying to do this individually, because for each vendor it makes sense to only focus on the best business case, which means many times the subspecialties are going to get neglected. And so one of the ideas, which unfortunately is not mine, it comes from Ross and his team, is to find a way to actually share the understandings that each of us has about workflow, and to do that in an intelligent way so we're not having each vendor make their own individual investment. Those understandings of workflow could be shared so that all of us have access and don't need to make that initial investment.
That's what a great note to close the session. I just want to once again thank Raj Rotwani, Chris Engdahl, and Ross Teague for really a tremendous presentation. We got a lot of comments during the presentation about how much people enjoyed it. Slides will be available at www.healthitsafety.org. The other thing is that if you have a question that was not answered, we will forward it to the presenter that we think it was targeted toward, and they've agreed to take a look at those and to respond. So have a great rest of your Friday and weekend, and I just want to thank everybody for attending and once again thank the presenters. Take care, everybody. Bye-bye.